We have two speakers for this session, Susan Lopez-Payan, who I introduced earlier this morning, and Rebecca Nielsen. Rebecca Nielsen is a senior advisor at Levitt Partners. She aids both public and commercial clients in strategic planning, assessing new markets, and identifying opportunities for product expansion. Her research interests include value-based payment readiness and chronic disease management and prevention. Prior to joining Levitt Partners, Rebecca held a variety of positions with United Health Group, including Senior Director of Specialty Analytics and Management Products at Indirex, Program Officer at Optum, Product Director at Optum, and Director of Business Development at Indirex. Rebecca has an MBA from Harvard Business School. You can please welcome Rebecca.
And I'm just going to do a very brief introduction, so don't get worried. We're going to hear from Rebecca real soon here. So I am going to just talk about the background of this toolkit a little bit so you have some foundation. And then Rebecca is really going to go into the nuts and bolts of the toolkit itself. So this toolkit was developed as a product of a national demonstration project. I spoke about it I just touched on it on my talk this morning a little bit. This project is being funded by the CDC and led by the NACDD, and then we brought in Levitt Partners to be really experts in this area to kind of build out this website and this toolkit. The audience for this toolkit is payers, and so we really wanted to develop a tool that helped all kinds of payers understand what was necessary to gain coverage for the national DPP. So the process was, we do have experts at the table, but we actually interviewed many payers to figure out the content of the site and the structure and making sure that it really speaks to the audience. So you might think, well, I'm not a payer, why do I need to know? We're going to take you through a little bit of the website so that you start to see, and for me, it's a huge education so that I understand the language, and I understand there are options now and different roads to take to coverage. And that alone, I think, is really important for us who are not in that world to understand, especially in public health. We may not have that kind of experience in our daily work, so it's really helpful to kind of understand. The other thing that's really key in this toolkit is it's so accessible. So this project, this demonstration project, is funding 2 different states. It's with Maryland and Oregon. It's a 2-year project, and we're in our 2nd year. And what we wanted to do is really build some models so that other states might share what has worked. And these states are really tasked with different ways of rolling out the national DPP. So they're going to have to figure out the recruitment and the retention and the payment and all the ins and outs of actually delivering and covering this service. And also what was very important is that we developed some models for the rest of the states to use. So this product, this national toolkit, is a product of that particular project. Let's see. So I'm going to just navigate a little bit through the toolkit itself. Again, just very broadly, and this is there. It's kind of coming up now. So I think what you need to know too is this is a very comprehensive website. So what we've done as a team with the NACDD consultants that I told you about on our diabetes team, so that we learn this information, we're actually doing teach-backs with each other because the information is pretty complex, pretty difficult to understand, and at first it's like overwhelming to look at the whole thing. So we're doing teach-backs within our own team so that we understand this website better and we can offer it to all of you. So this is the home page, and again, it's a very dense website, so I would figure out how to take some time to really get into it, grab a cup of tea or whatever your favorite drink is. That didn't turn out right, I'm so sorry. And just really, take some time with it so you understand the value of it and you can share it with your partners. So like any good website, there's a home page. You can see the kind of structure here. So what's nice about this is it's sort of one-stop shopping. Again, the National Diabetes Program has grown so large over so many years with so many different organizations producing tools that now this website offers, although the topic area is coverage, it's sort of one-stop shopping for a lot of information. So if you're looking for information to build a case for covering the DPP or just educating your partners about the National Diabetes Prevention Program, this is a nice place to go because it's all organized for you. We've also had other speakers earlier today talk about evidence. What's the evidence for this? What's the evidence for that? The evidence behind the National Diabetes Prevention Program is also in this website. So you'll want to kind of dig in there and find those jewels. So we have a lot about the National DPP itself. We have an About Us page, what we're doing, using the site, how to navigate it. All of the sections are sort of laid out the same so that it's designed to be easy to understand. You'll notice there isn't a search feature, which, at first I'm like, what? No search feature? How are we going to find anything? Well, the organization is good, so you really don't need that search feature, I have found, which is quite amazing. Getting started and just making it easy. There's a glossary of terms. This is an environment where I've had experience where the terms that we use in public health aren't the same. They don't have the same meaning across the street in the department that covers Medicaid. And so, this is to help everyone kind of get on the same page. And also, we want your continual feedback. So there's a contact us page as well. So under the National DPP section, you'll see the first section is Explore, and you'll also find that across the other sections as well. There's an overview, there's evidence, economic impact, diabetes burden, timeline, participating payers, which is again what everybody wants to know, quality metrics, and additional resources. So Rebecca is going to go into these sections a little more than I am. So with that introduction, I'm going to really turn it over to Rebecca, who's the expert, and she's going to take you on a navigational tour of this. And I think that what I do want to announce as well, because it is so deep and because there's so much information here, that the CDC has announced that they're going to offer some limited number of states a one-day workshop to learn more about this tool. It's a hands-on workshop to get into the nitty-gritty, go over some case studies, how to really learn this tool, and maybe, real-world experience, what you need to take to a payer in Iowa. So Iowa was one of 4 states chosen for this opportunity. So over here, there's a sign-up sheet. Yeah, I think it's big. There's a sign-up sheet. We're still working up on the details of when that's going to be, but it'll probably be spring. There'll probably be a limited opportunity, so we'll probably have limited seats. So we're just still working out those details, but I wanted you to be aware of that. So the sign-up sheet is not for the actual event, but it's a sign-up sheet for your interest. So once we figure out the details, we'll send them out to those who are interested, and then you can respond. So congratulations, Iowa, on that one.
So Susan and I are on the phone a lot together, but I don't get to see her in person very often, so this is a treat. So I'm originally from Salt Lake City, and my early impressions of Iowa hospitality were from the Music Man musical. And I really haven't spent much time here, but I can attest that that totally misrepresents how you receive people to your state. I sat by someone from Iowa on the flight over, and she was so gracious, and then I've had the privilege of chatting with a number of you just in the last few minutes. So thanks Jennifer and Kelly and Brad, and I hope I get to meet others of you. But one thing I realized as I visited with some of you is that a number of you are quite expert in the diabetes prevention program and in supporting participants of that program. And so at kind of the 11th hour, I proposed to Katie and some of her colleagues that maybe we have the mic on the ready at junctures during this conversation so that you can share insights that we try to represent on the website, but that really reside within individuals who have experience implementing the program. And I kind of extend an invitation to those of you as you navigate this site, if you see information that's missing or insights that could help payers or anyone who comes to the site, that you'll either submit them to the site or find me, because we'd be so pleased to incorporate more of those reflections. So I appreciated so much Susan's focus on this homepage. Why don't we take a moment just to look at the structure of the site and understand the intended audience, and then how it might be relevant to those in this room. So we have this national DPP section, and this has a lot of rich information that's really audience agnostic. This isn't just for a particular type of payer or necessarily for payers only. And so if you were to come to the site seeking information about the national DPP, this will be a tab where you can find a lot of good resources, and we'll drill down a little bit into that in more detail. Then obviously we have this Medicaid agency section. So this section is to support state Medicaid agencies who are contemplating covering the diabetes prevention program for their Medicaid beneficiaries. And there are 3 states at present who cover this program for Medicaid beneficiaries. Do I have any hands? Are people aware of who those states are? So Minnesota, your neighbor to the north, covers it for Medicaid beneficiaries. Montana has been covering the program for some years now for its Medicaid beneficiaries. And then California, as of January 1st of 2018, will be covering it for its vast Medicaid population. And so that's exciting, and that momentum creates interests for other state Medicaid agencies to consider this opportunity for their populations, many of whom are at risk. And so this information has deep detail around what a state Medicaid agency would need to know to make that coverage decision. We'll take a little bit of time with that section here in a moment. Now we have Medicaid MCOs. So the acronym MCO stands for Managed Care Organization. And these are entities in Iowa. This would be AmeriHealth Caritas or AmeriGroup or United, who take possibly a set payment from the Medicaid agency to provide care for, to provide insurance for Medicaid individuals. And so this is information, to help them decide whether to cover the program and how to implement it and how to build networks with DPP providers. In states where the state Medicaid agency is not covering the program, Medicaid MCOs can still elect to cover the program as a value-added service. There are MCOs in states who, of their own volition, cover the diabetes prevention program because they think it's the right thing for their members. They feel like there's a strong business case. They feel like it will draw members to the plan. And so this is to support those MCOs in making that decision whether or not their states are covering it at the Medicaid agency level. Next, we have commercial plans. So in Iowa, this could be Wellmark or United, insurers that cover large employers or small group employers or individuals on the state exchange. And this area of the site supports those payers in making the decision whether or not to cover the program, and if so, how to best deploy it. One interesting reality about the diabetes prevention program is different segments of the population respond differently to the program. Seniors tend to be more adherent. They tend to lose more weight. Medicaid beneficiaries tend to have a harder time for reasons that might be that might seem apparent. And then the commercial segment kind of sits in the middle in terms of the business case or the potential return on investment. And so a commercial payer could come to this section of the site to get and glean more information about whether or not to move forward with coverage. Next, we have the Medicare Advantage section of this site. And in Iowa, this would be highly relevant to Aetna and Humana and United, who are covering Medicare beneficiaries. And as was mentioned, it's probably been mentioned a couple of times today, as of April 1st, Medicare will cover the diabetes prevention program for all Medicare beneficiaries, and Medicare Advantage plans will be covering it for their beneficiaries as well, which is a tremendous windfall for the program. One phenomenon that we see is that sometimes there's kind of a domino effect or a catalyst effect in different markets, where if one large employer or if one large payer starts covering the program, others become aware of the program, and then others kind of join in either covering or referring or implementing the program. And so it's likely that now we have seniors across the country who will have coverage that other payers will take a second look, and even payers who have Medicare Advantage lines of business will consider covering the program for commercial lines of business or for Medicaid lines of business. You'll see that this section of the website is relatively empty. Does anyone know why? It's because it wasn't until November 2nd, just a couple of weeks ago, that CMS finalized the specifications for Medicare coverage of the diabetes prevention program. And Kelly and I were talking earlier. She's a DPP lifestyle coach, and the standards that a DPP provider has to meet in order to become a Medicare DPP supplier are very, very rigorous. And so it will be interesting to see how that unfolds, and we can talk about that in a little more detail as well. So this is the overall structure of the site. Now let's go in a little bit deeper for the next few minutes. And then I'm going to try and be intentional about pausing and asking for your thoughts or insights or questions. But please interrupt me if they come to your mind before I think to look up. Actually, I have one question I wanted to ask here right at the outset. So for those of you who are involved in the diabetes prevention program in some way, could you raise your hands? Now keep your hands raised if the participants you work with or have oversight for are covered by insurance. Okay. So there are not many hands left up. So that's one kind of compelling impetus for this website, is that many, many program participants right now are paying out of pocket, or it's being funded by a health system, or it's being funded through grant dollars from the CDC or other entities who kind of believe in the purpose and the mission of the diabetes prevention program. But there's a huge need to get sustainable coverage for the program. So that's one reason why this website exists, is so that payers and purchasers can see the rich evidence behind the program and have all of the information at hand that they need in order to make a coverage decision. We're going to spend a little bit more time here because of the audience, but we'll move across all the sections as we have time. So don't get nervous if we spend a little more time here than seems judicial, but there's a lot of great information here that you very well may want to revisit in time. One thing that's nice about the site is it provides a nice history of the program. So let's start with that by looking at the evidence. So you're aware that in 1996, the National Institutes of Health initiated a randomized clinical trial with 3 cohorts of individuals, and one cohort of individuals had one-on-one counseling with a case manager over the course of the year. And that case manager helped that individual set and achieve goals around modest weight loss and improving nutrition and exercise. And another cohort had metformin, and then another cohort was a control group. And at the end of that intervention, the individuals who'd had that one-on-one counseling over the course of a year, their risk of progressing to type 2 diabetes had fallen sharply by about 58%. And for those in the cohort who are older, their risk of progressing to type 2 diabetes had fallen by about 70%. And that was striking. And that trial was published. There have been some follow-on studies of those same cohorts, and the impacts of that counseling have been lasting. And so, as you might imagine, there was some concern about the expense associated with one-on-one counseling to support individuals in reducing their risk of diabetes. So were translational studies conducted to see if there might be more cost-effective means of realizing those same outcomes. And so the Deploy pilot study that involved the YMCA tested a hypothesis of whether or not an individual could realize those same outcomes in a group setting with a layperson facilitator as opposed to a licensed practitioner. And they realized, again, very striking and positive results. So moving down this evidence page, another big milestone in the story of the diabetes prevention program was a multi-state implementation that was funded through a Healthcare Innovation Award grant where YMCA sites across the country supported Medicare participants. I mentioned earlier that Medicare participants tend to be adherent to the program and to lose quite a bit of weight. And RTI International did an evaluation of medical cost savings for these individuals. And over the course of, in the first 15 months, the Medicare participants who participated in the DPP at the YMCAs realized over $2,600 in medical cost savings. And that's just in the first 15 months of the intervention. They look at their claims as opposed to the claims of other seniors with prediabetes, and those who participate in the program saw a reduction of $2,600 in medical cost. And who knows the approximate cost of the DPP program for one participant for the year? It's about 400, about 400 or 500. It also depends on who the participant is. And so, is that would you make that bet? If you felt confident you could get $2,600 in medical cost savings, would you invest that 400? So that takes us to the next piece of our story. And that is last March, the CMS, the Centers for Medicare and Medicaid Services, Office of the Actuary, those are the people who have lots of calculators and they're very brainy. They went through all of the data to date about the diabetes prevention program, and they concluded this: $2,600 is bigger than $500. They said, we're going to do it. And so some of you remember what a watershed moment that was when they said, we intend to expand coverage of the diabetes prevention program to all Medicare beneficiaries, and we do not expect it will increase net Medicare spending, which is a fancy way to say, and we don't think we're going to lose money. So that was exciting news. So let's keep moving down this timeline in the story. The Community Preventive Services Task Force, they looked at a ton of literature and studies around lifestyle interventions, including the DPP and those programs that very closely resembled the DPP, and they said cost effective, which means this is a very good use of money. The Institute for Clinical and Economic Review, they also put out a final evidence report and said cost effective. Again, that term cost effective means it's a very good use of funds. The term cost savings means you're going to get more money back than you put in. So what the Office of the Actuary realized is that it was cost saving. They'd get more money back than they put in to support Medicare beneficiaries. The verdict is still out whether and when you'd realize the return on investment for other populations. But even so, these are very strong endorsements from very respected institutions that the DPP is a very good choice to make. Okay, last thing I'm going to mention on this page before we move on, can you tell we're not going to get through the whole site, is just a brief reference to the USPSTF recommendation. So as of January 1st of 2017, ACA compliant plans are required to screen individuals for diabetes, with abnormal blood glucose levels, and to refer them to intensive behavioral counseling. And the gold standard for this intensive behavioral counseling is the Diabetes Prevention Program. So I mention this terribly long acronym because this also gives commercial payers a nudge to start covering the Diabetes Prevention Program, because it's incumbent upon them to be, in order to be ACA compliant, to cover intensive behavioral counseling, and the recommendation references the Diabetes Prevention Program. So let's move to the next section, but before that, any comments or thoughts? Okay, let's move to the next section. So I'm going to show you something fun, which is the timeline. This is another nice place to come if you want to refresh yourself on the story we just told. This just shows the history of the Diabetes Prevention Program in a chronological sequence. There have been a lot of wonderful milestones. January 1st, 2016, the Minnesota Department of Human Services starts offering it for their Medicaid beneficiaries. So that's also interesting to browse through. The reason why this is all on the site is some of these points of information address the questions of a plan. Why should I be thinking about this? But the same information might also be helpful for many of you who work on the provider side. Okay, next we're going to go to participating payers. This is a page on the site that I frequent and that you might decide to frequent, especially to the extent you're advocating for coverage of the program with your own employer or with other payers. This is helpful for them to understand the momentum around the program. So what Levitt Partners did back at our office is we started doing web searches, and we found out the entities that have publicly acknowledged or have posted that they're covering the Diabetes Prevention Program, and then we keep updating this list. These are among the participating health plans, and then we have a list here of participating employers, and then we have state employee coverage. I find this particularly compelling. So I'm going to ask a really leading question. Who is the largest employer in most states? The state. And so it is thrilling when this list gets longer. And right now there are 10 states who cover the Diabetes Prevention Program for state employees. There's also some reasons why it makes a lot of sense for states to cover the program for their employees, even if they're purely thinking financially, and that is, in many states, state employees tend to be somewhat older, and diabetes tends to be a huge cost driver, and in some states there's lower employee turnover among that older segment of the state employee population, and those all contribute to a stronger return on investment. Return on investment meaning that it's more likely that the medical cost savings will eclipse the cost of the program itself, and then that creates a financial windfall for the state. So one thing that comes to my mind sometimes is that good nutrition and exercise, those don't only, if you kind of get those things in hand, you're not only preventing diabetes, you might be preventing cardiovascular disease or cancer. And so sometimes I think of this not as the Diabetes Prevention Program, but as the Chronic Disease Prevention Program, or it could be even broader than that. I've had a number of conversations with individuals who've underscored that people are so grateful to participate in this program, and it has all sorts of benefits that we can't reduce to dollars, but that are meaningful and significant and could be intergenerational and impactful. So this is a fun map, the 3 states that I mentioned where the DPP is covered. So I'm just going to talk about some aspects of this section just for your awareness. So if Iowa Medicaid is trying to decide whether or not to cover the diabetes prevention program for Medicaid beneficiaries, it's not likely that they can just go ahead and make that decision without amending their state plan or without applying for a waiver, because Medicaid is a joint state and federal program. The state doesn't have total license to make changes to what it covers. And so a lot of what's in this section is intended to support a state Medicaid agency in knowing kind of what boxes it needs to check and what processes it has to be able to follow in order to cover the diabetes prevention program. So I think just to illustrate that point, I'll just, okay, so here we go. Attaining coverage through a Medicaid state plan. So I believe Minnesota had to amend, Montana had to amend their state plan, which is a bit of a process. Minnesota did not. They happened to have the authority they needed in order to cover those services. But there's also paths through applying for a waiver. And so you can see this is kind of nitty-gritty information for a state Medicaid agency that wants to move forward. Let's move to Medicaid MCOs for a moment. So if you look at Medicaid MCOs here at this highest level in commercial plans, these kind of resemble each other. They both have a section on delivery, they both have a section on contracting, coding and billing, data and reporting. So let's talk about delivery for a moment, in part because managed care organization would have interest in understanding what best practices exist around delivering the program, and because I think this is an area where people in this room have a lot of expertise. So what we've attempted to do in the site, we interviewed a lot of vendors who deliver the program, a lot of managed services organizations that support DPP sites, and we attempted to aggregate some best practices around delivering the program. And this is how the site's organized. So this options section indicates the fact that you can offer the program in person, online, through distance learning. You could work with a managed services organization or seek CDC recognition yourself. And then here we get into some of the sections around that attempt to surface some best practices for screening and identification, recruitment and referral, and enrollment and retention. So I'm going to just share a couple of my favorite stories around recruitment strategies and retention strategies, and I hope you'll be thinking of things that have worked for you in terms of recruitment and retention. So get your thoughts ready. So there is a safety net hospital in Colorado called Denver Health, and they wanted to test drive the diabetes prevention program. They had some grant funding from the CDC through AHIP, which is an association of health plans. And so Denver Health wanted to find efficient ways to recruit individuals into this new program. And they did something that was rather clever. And so I like to talk about it just to get people's brains thinking about how and if this could be helpful in your context if you're working with the diabetes prevention program. So because they were part of a health system, they went to their EHR and they generated a patient registry of individuals who were highly likely to be eligible for the program based on the codified eligibility criteria for the program as established by the CDC. And then they sorted all those patients by PCP, by who their primary care physician was. And then they called up each of those PCPs and they said, or emailed them, I don't know. They said, here's your list of patients who has prediabetes or is highly likely to qualify for this program, would you feel okay if we reach out to them and tell them that you're comfortable with them participating in the diabetes prevention program? So do you want to guess what the PCP said? They said, that's great. Go for it. Like, bless you. And so those PCPs gave permission. So then back at Denver Health, a staff person gets on the phone and says, Sarah, your PCP, Dr. Hansen, recommends that you participate in the diabetes prevention program, and we've ascertained that you're at risk, and this is how the program works. 50% of the people who got that phone call enrolled, which is a pretty good number. So Denver Health also tried just calling people straight from the patient registry without talking to their PCP. And so this is how the other conversation goes. Sarah, we've identified that you're at risk for the diabetes prevention program. Here's the program. Will you enroll? Sarah's likelihood of enrolling in that instance was 1 in 10. So the people on staff at Denver Health thought, well, we can either make 10 phone calls to get one participant, or we could make 2 phone calls to get 1 participant. And they didn't even have to submit this to the Office of the Actuary. They decided that 2 calls was better than 10 calls. And so they've published just their experience, and I think kind of a fun term to kind of remember this learning is the power of the PCP. So if the primary care physician can somehow be involved, even if they don't talk to the participant or see the participant, but if somehow you can get their blessing, an individual is much more likely to enroll. These are just some recruitment strategies. So while we were building the website, we chatted with the people who've been doing this for a long time in Minnesota with Medicaid beneficiaries and the folks in Montana, and they shared what they do to try and get people to enroll. So we have the power of the PCP. Another theme is timeliness. So if you can catch someone right after they see their result that they have prediabetes, or right after the holidays when they're ready to make their New Year's resolutions, or right before the weather gets warm enough to go outside in a swimsuit, there's some timeliness factors to getting people to enroll. So lots of good fodder here on this page. Come here and read about best practices for recruiting, and then consider reaching out to some of these entities that have been doing this for a long time with Medicaid populations. Let's talk a little bit about retention and we'll stay in this MedicaidMCO section, although they're mirror sections under these other verticals. So let's talk about enrollment and retention. Another leading question, okay, look at that top line. Why is it important to retain individuals in the DPP? Because you get better outcomes. And there are a couple of other reasons. DPP providers often, almost never, get paid the whole fee up front. They usually get paid on a performance basis, so they get paid as participants attend sessions or lose weight, and that's absolutely the case with this Medicare coverage. CMS is only passing dollars to DPP providers in the first year if people participate, and then as they lose weight. So it's important to keep these people in the program. And so let's talk a little bit about strategies for retention. So we mentioned that Medicare beneficiaries or seniors tend to stay in the program longer. Medicaid populations can really be the opposite. They might have a lot of barriers to attending sessions week after week. And some of those barriers can be addressed through a number of strategies. A number of states that cover this program for Medicaid beneficiaries, so Minnesota, Montana, and MCOs who are covering this in other states, try and identify ways to support participants with transportation and child care and maybe a healthy snack. Up in Minnesota, they've translated the curriculum into a number of other languages to support populations who don't speak English and don't speak Spanish. So these are some ideas around retention. All right, why don't we've got about 5 more minutes. Let's talk about Medicare Advantage, unless there's a section we've moved over that people want to dive into a bit more. So coding and billing, data and reporting, this is kind of the plumbing and wiring associated with implementing the program if you're a plan that's very helpful for them. Information about contracting. But let's move to Medicare Advantage. So I mentioned in March of 2016, the Office of the Actuary certified that expanding coverage to Medicare beneficiaries wouldn't increase net Medicare spending. Fast forward quite a few months, November 2nd, they finalized the requirements for Medicare DPP suppliers. So Medicare DPP suppliers can start enrolling in Medicare, and they'll enroll as Medicare suppliers to provide the DPP. They have to have full recognition from the CDC in order to do so, or what's called preliminary recognition, which the CDC hasn't really codified yet. But I believe they have to have at least 12 months of data that suggests that they're kind of on the track towards full recognition. They have to have HIPAA compliant processes. They have to be able to report overpayments. They have to be able to be subject to audit. Their coaches have to meet certain eligibility requirements. I believe the lifestyle coaches have to have an MPI number, which is a bit of a hassle to secure. So they're just really high. It's a really high bar for entities to become a Medicare DPP supplier. You may also be aware that online vendors at present cannot secure reimbursement from CMS for providing the program to Medicare beneficiaries, which is a challenge because online vendors can service so many individuals at scale. But it's likely that CMS has concerns about fraud, concerns about self-reported weight measurements, and with in-person sessions, they can monitor and manage that more effectively. But hopefully we'll get to a point where all valid and high-quality DPP vendors can serve Medicare participants. So there are online DPP programs available for someone who's in a home setting. And some of the vendors who deliver online versions of the program have adapted their program to all types of populations, to Medicaid populations or dual populations, and so those flavors of programs are becoming more abundant, and so a home health provider could certainly have a hand in referring or recommending the program to someone. You're probably aware, this was probably brought up in an earlier session, that it's pretty simple to identify if someone qualifies for the program. There's just kind of that 6 or 7 question risk quiz that takes about 46 seconds to take, and that enables someone to be eligible for the program. You know, we are out of time. It's been a pleasure. I hope you'll use the website. Feel free to submit feedback for how you think it could be more effective, but it's exciting, the momentum around the program and the potential impact this can have for individuals across the country. So thank you so much.